Welcome to this educational program. This module discusses erectile dysfunction, or ED, occurring after radical prostatectomy for prostate cancer. This information is taken from a recent review of the medical literature and attempts to be as comprehensive as possible. This material is independently produced, and the mention of any drug or medical product does not imply its endorsement. Nearly 10% of men in North America will be diagnosed with prostate cancer in their lifetime. Radical prostatectomy is an accepted curative treatment for prostate cancer and has become a common operation. Unfortunately, it can cause or worsen erectile dysfunction. Radical prostatectomy involves the removal of the prostate, part of the seminal vesicles, and the ejaculatory ducts. The neck of the bladder is then sewn back to the cut end of the urine channel or urethra. Unfortunately, the nerves that stimulate the penis for erection, the cavernous nerves, sit right next to the prostate, so they must be moved out of the way or cut during prostatectomy. There are several reasons why ED may be associated with prostatectomy. It may be present already and unrelated to the prostate cancer. It may be caused or worsened by the effects of prostate cancer. And of course, it can be caused or worsened directly by treatment for prostate cancer. ED is a common condition in the general population and may be present before prostate cancer ever becomes an issue. It is estimated that 15 to 30 million American men suffer from ED. The chance of experiencing problems increases with age, and about 1/3 of men aged 50 to 90 experience it. In a large study of more than 1,200 men undergoing prostatectomy for prostate cancer, 44% of them had ED before undergoing treatment, and 16% of them were totally unable to have intercourse. Radical prostatectomy can have several effects on sexual function. As mentioned, nerve injury can lead to erectile dysfunction. Removal of the ejaculatory system means that there will be very little to no semen fluid during ejaculation, and cutting of the vas deferens will create infertility. Some men may also experience less sensation of orgasm or urine loss during sexual activity. Along with the physical effects, radical prostatectomy can have an emotional toll as well. Some men may experience emotional stress and anxiety about their cancer diagnosis, anger and fear, loss of their normal sense of control, impaired body image and confidence, or even clinical depression. Unfortunately, with the early loss of erections after surgery, some men become discouraged, and this situation is worsened if there is also associated urine leakage. His partner, in trying to be supportive, may not push for intercourse, and this can be mistaken by some men as rejection, which again worsens his discouragement. As this continues, the couple may unfortunately settle into a relationship without vaginal intercourse. It is difficult to quote percentages of just how common ED is after surgery, as multiple factors can affect its likelihood, including the definition of ED used, how long it has been since surgery, the quality of erections before surgery, the age of the patient, his stage of cancer, whether nerve sparing was done or not, as well as the surgical technique and the experience of the surgeon. With this in mind, it is easy to see how numbers ranging from 10 to 90% have been reported. Overall, about 50% will experience some degree of ED, with less than 10% of men reporting the same erectile function after surgery as before. As you likely already know, during prostatectomy, the penile or cavernous nerves can be peeled off of the prostate and spared. This is termed a nerve-sparing radical prostatectomy. One side, unilateral, or both sides, bilateral, may be spared, depending on the location of the tumor. Nerve sparing clearly improves a man's chances of recovering good erections after surgery. Unfortunately, not all men are candidates for nerve sparing, and sometimes the final decision on nerve sparing has to be made in the operating room. Even with a nerve-sparing procedure, the nerves may get stretched or bruised in the process of peeling them off the prostate, so that even well-preserved nerves may not function normally right away. Indeed, few men recover full function in less than 6 months, with most taking 12 to 24 months to recover fully. Early after surgery, urine control usually returns before erections. It is important to remember that if no erections are experienced initially, you should not despair. If you have had some nerve sparing done, things should improve with time as the nerves recover. Furthermore, erectile dysfunction absolutely does not mean that there was any problem with surgery or that prostate cancer has not been successfully treated. There is great interest in the medical community around the topic of so-called early penile rehabilitation, which is the early use of medications or devices after surgery to preserve the health of the penile tissues while waiting for the nerves to recover. Initially, the loss of erections after surgery is caused by nerve injury. However, while the nerves slowly recover, damage to the vascular erectile tissue can ensue from lack of blood flow into the area. This blood flow from the erections that men normally have every day brings oxygen to the tissues and helps keep them healthy. There is concern that in the early period after surgery, loss of erections will result in damage to the tissues from lack of oxygenation. In theory, early use of medications and devices after surgery may help prevent this damage, so erections will be stronger once the nerves do recover. Success in achieving some degree of erection early after surgery can also limit the psychologic effects of early erection loss. Pills, injections, topical agents, and vacuum devices have all been used for early penile rehabilitation. Unfortunately, as of today, this theory has not been definitively proven. However, it is recommended if you had good erections before surgery, if erectile function is important to you, and if you can afford it. As with any treatment plan, this should be discussed in detail with your doctor before being undertaken. As mentioned, ED can be treated at any age, and many treatment options exist. The best treatment varies depending on an individual's situation, and your doctor will use all the information at hand to choose the best treatment for you. Treatment options include lifestyle changes, adjusting medications, psychotherapy such as counseling and behavioral modification, oral medications or pills, topical medications such as creams and gels, vacuum devices, injection of medication directly into the penis, and surgery, including penile implants. These treatments are briefly discussed in the next few slides, and many are reviewed in much more detail in separate modules. All patients, before and after prostate cancer treatment, should strive to introduce lifestyle changes which may improve the quality of their erections and other aspects of their sexual function. These include smoking cessation, an exercise program that emphasizes cardiovascular conditioning, improving dietary habits, and weight loss. Finally, couples should take time to focus on their relationship and make changes where necessary. A psychological assessment and psychotherapy may be appropriate for some patients. This will usually consist of a series of interviews with and without your partner, with a sexual therapist, psychologist, or psychiatrist. Questionnaires may also be used. The aim of psychotherapy is to assess and deal with the emotional impact of cancer diagnosis and treatment, and the sudden change to one's sexual function. Related problems, such as depression, can also be dealt with. Beyond lifestyle changes, oral medications, or pills, have become the standard of initial treatment for ED. 3 medications are now available for the treatment of ED: sildenafil, or Viagra, vardenafil, or Levitra, and tadalafil, or Cialis. All 3 of these fall within a class of drugs called PDE5 inhibitors, as they block an enzyme in the penis called phosphodiesterase 5 to improve blood flow to the erectile tissue. The effectiveness of these medications is difficult to predict, and among other things, varies with age, erectile function before surgery, and what type of nerve sparing was performed. Medications would only be expected to work if at least one nerve was spared. As shown on this slide, nerve sparing determines the effectiveness of oral pills for ED. If bilateral nerve sparing was performed, 54 to 80% of men may achieve good erections with these pills, while if unilateral nerve sparing was done, roughly 40 to 50% will achieve success. And if no nerve sparing was performed at all, then only a few men might see a response. Overall, one study showed that 71% of men continue to use these pills 3 years after surgery, which speaks to their effectiveness. As noted earlier, these pills can be used early after surgery to prevent damage to the tissues while awaiting nerve recovery. Typically, a full or half-strength dose is suggested to be taken daily or every other day initially. As nerve function begins to recover, higher doses can be taken until it is determined which drug at which dose gives the best response. It is important to keep in mind that every man's situation is different and will determine his response to treatment. Age, health, prior erection status, cancer specifics, and treatment variables will all affect one's outcome. It is also important to try to combine treatments with lifestyle changes. Remember that the dose of the pill required may change with time, up or down, and there is no best pill for everyone. You may need to try each of them before choosing the best one for you. Further information about these medications is detailed in a separate module. If at first oral medications do not work, do not despair. Review things with your doctor, who can counsel you on what to do next. It may simply be too early from your surgery to know how much nerve recovery you will get. Depending on your situation, your doctor may simply advise you to try adjusting the dose of medication or try a different pill. He or she may also discuss alternative treatments or combination treatment with you. Finally, if there are emotional or psychological factors playing a role, these may also need to be addressed. Alternative treatments beyond oral medications include topical therapies, vacuum devices, injections, and implant surgery. There are some medications available that can be applied topically and rubbed into the tissues. The most commonly used is called MUSE, which stands for Medical Urethral Suppository for Erection. This contains the drug prostaglandin or alprostadil. It is sold as a pellet that is applied into the tip of the urethra, then rubbed in. In many men, MUSE does provide an erection within 10 minutes that may last 30 to 60 minutes. Unfortunately, it may cause discomfort or burning in the penis, urethra, or testicles in 20% of men, and it is relatively expensive. Up to 57% of men have had successful erections at home with MUSE. However, the overall satisfaction rate is only 20%. Mechanical vacuum devices, also called vacuum constriction devices or VCDs, create an erection by drawing blood into the penis, engorging and expanding it. Once the blood has been drawn in, a constriction ring is placed around the base of the penis to keep it in. As the figure shows, the devices have 3 components: a plastic cylinder into which the penis is placed, a pump which draws air out of the cylinder, and an elastic band which is placed around the base of the penis to maintain the erection. Vacuum devices have the advantages of working well regardless of the underlying cause of ED, and they have been advocated by some for early use after surgery. They do avoid the use of medications and their associated potential side effects, and there are minimal ongoing expenses once the device is purchased. On the downside, the devices are somewhat cumbersome to use for some and require manual dexterity, and they are expensive to purchase initially. They also produce a less natural-looking erection, as everything on the inner side of the constriction band is soft, so the penis tends to be somewhat floppy. Medications injected directly into the penis are extremely effective, fast-acting, and create a normal-looking erection. Use of these drugs is discussed in detail in a separate module. Several medications, particularly papaverine hydrochloride, phentolamine, and prostaglandin or alprostadil are used. Alprostadil is marketed on its own as Caverject. Commonly, All three medications are mixed together in varying strengths to produce a product called trimix. This may also go by other names. These drugs work directly to increase blood flow into the erectile bodies of the penis. Once again, these drugs have been used for early penile rehabilitation after surgery, and their regular use 2 to 3 times per week has been shown to help maintain healthy erectile tissue in some studies. As erections return, one can switch over to pills or continue on with the injections. Injections are extremely effective, fast-acting, and create a normal-looking erection. Again, they may be cumbersome for some to do and require manual dexterity and training to learn the technical skill of injecting. Patients find the injections uncomfortable at first, and the medication itself may cause some local discomfort. The major potential risks of these medications are priapism, which is an abnormally long-lasting erection, and scar tissue formation in the erectile tissue. Overall, about 60% of patients who start this therapy will continue on with it. Any combination of oral medications, injection therapy, and vacuum devices can be used to improve their effectiveness when treatment with one alone is not satisfactory. Penile implants, or prostheses, are a last resort for some men, when other options are not suitable or have not been effective. One should wait at least 2 years from the time of surgery and try other methods before resorting to a prosthesis. There are several types of implants, and these are discussed in more detail in a separate module. This is specialized surgery done by urologists with an interest in this field. Results with penile implants can be quite good. One must understand that there is no going back from this surgery, as the existing erectile tissue is damaged in the process of placing the implant. Also, there are certain risks to be aware of, such as infection, erosion, and failure of the device. In summary, erectile dysfunction is common even before a diagnosis of prostate cancer. Prostate surgery, unfortunately, can cause or worsen ED in many patients. The likelihood of this happening and the severity of it depend on the quality of erections before surgery, the age of the patient, and whether or not any nerve sparing was performed. After surgery, it may take many months for nerve function to recover. While waiting for this recovery, you may be advised to try pills, injections, or a vacuum device periodically. Use this time also to focus on your relationship and to make appropriate lifestyle changes to maximize your sexual function. Oral medications are often successful in improving erections after a nerve-sparing operation. If unsuccessful at first, however, try not to be discouraged. Be patient and be willing to try different doses or different pills. Beyond pills, other very effective treatments are also available. This slide lists some of the many resources available where you can find more information about erectile dysfunction. These references were also used to assist in preparing this presentation. We sincerely hope that this module has furthered your understanding of erectile dysfunction after prostate surgery. We wish you the best for the future, and thank you once again for viewing this educational program.